Are you ready?
I'm ready.
Okay. Well, ladies and gentlemen, we're about to get started. Greetings to everybody. I'd like to call to order the Regional Cancer Treatment Task Force. And we have a short agenda today, but I think a productive one. First and most importantly, there's snacks on the table. And we don't necessarily, we're a public agency. If there's leftovers, they just go upstairs and staff eats them. But you guys can, Darlene, take them to the hospital, okay? So, okay, give it to those A-listers, Darlene, okay, to those people who get the grade A's. But let's go ahead and call the meeting to order. I'll do a roll call. If I goof up, correct me, or if somebody's here substituting for somebody else, correct me as well. County of Riverside, District 3, Chuck Washington's office. Anybody here? They didn't make it, okay. City of Temecula, Mayor Edwards and myself are here. City of Murrieta, we have Mayor Rick Gibbs. Rick, you're here, right?
I'm here.
He's right here.
Oh, you moved, okay. He's driving me nuts. Okay. City of Menifee, I'm told Councilmember Soba couldn't make it. She's got a council meeting tonight, but somebody's here in her stead. Kayla, welcome. Good to have you. All right. City of Lake Elsinore, do we have a representative from Elsinore? Okay, not today. American Cancer Society. Okay, great. Good to see you. Kathy? Hi. All right. How about Michelle's place? Hi, Kim. We know you're here. All right. IEHP. Anybody here from IEHP? Nope. All right. Loma Linda University. Good to see you. Riverside University Health System? No. Scripps Health? Alice Fang, Senior Director, Corporate Business Development. Oh, that's with Scripps, I think. Alice, you're not here. Sharp Healthcare? Okay. Temecula Valley Hospital, our very own Darlene Wetton. And as I mentioned earlier, congratulate her. You're the only hospital in the region that got an A rating from,
Yep.
What was it, from Leapfrog? Okay. How do they name that Leapfrog? It sounds like the kids' game. It's kind of throwing me off. All right. UC Riverside School of Medicine.
Yeah, how did that happen?
You guys here? Nope. UC San Diego Health? Where? Hey there. You're welcome to come up to the front table. Okay, sounds good. Did you get anything to eat? Oh, okay, all right, very good.
Thank you, Mother.
All right. UC San Diego Health, I said that already. All right, Senior Director of, okay.
That's it, yeah.
Okay, yeah, Medical Directors, Dr. Amy Bremner. Dr. Amy, are you here? No. Dr. Mark Spicer? He's in surgery, okay. Dr. Evelyn Mendoza? Hi, Doc. Dr. David Horner? Hey, Doc. Doctor, he's on. I don't see him here. Okay. Oh, got it. All right, great. Tell him we said hi. Dr. Arun Kaira. Arun's not here. All right. Dr. Richard Chinook. Not here. And Dr. Julie Shiwenka. She's not here either. Doc? Okay. All right. A matter of formality, it's the public comment portion of our meeting. This is for things not on the agenda. Is there anybody here who wants to speak about something not on the agenda? I don't see anybody, so we'll move to our agenda items. Number one is cancer patient caregiver testimonials. Our first one is Natalie Flute, and she's going to give us a patient testimonial. Natalie, welcome today. Please make yourself comfortable at the podium.
Hello. I'd like to thank you all for having this committee. It means a lot. My name is Natalie Flute, single mom, 3 kids. 2014, felt a lump, didn't have insurance. So I got referred to this clinic in Elsinore from several people 3 different times, couldn't get a mammogram referral. One day I was there 4 hours, still couldn't get a referral. Finally, Obamacare kicks in, got my California covered California, got a mammogram that week. The nurse that referred me said, oh yeah, this feels bad. Did the mammogram, biopsy, got everything taken care of. Thought it was stage 2 with 2 lymph nodes. They wanted to do surgery. So I talked to actually Dr. Bremner, and she said lumpectomy reduction. I said, great, let's do it. But what about this pain in my back? Shouldn't we get this checked out? So I talked to an oncologist, and he said, yeah, let's do a PET scan. Sure enough, big, huge tumor in my spine. I have a fractured T7. You know, large breasts, your back hurts your whole life. You just kind of suck it up. But no, it was cancer, and it had fractured my spine. Needed to get a biopsy to see if it was actually metastasized breast cancer, and there were no neurosurgeons anywhere near me, so only 2 were in my insurance. One was in Pomona, the other one was in Rancho Bernard, or San Bernardino. So I went to St. Bernardine's, did a surgical biopsy, very traumatic, and sure enough, it was breast cancer. So now I'm stage 4. That was about 3 weeks after I was diagnosed originally. So the plan was no surgery after that. As the doctor said, it's like closing the barn door after the horses are out. So no breast surgery for stage 4. That was a big letdown. But what I did like about what the doctor said, and I have a good doctor, he said, we're going to manage your cancer. And my dad asked, what's the prognosis? And he said, the prognosis is a long, happy life. And that was one of the best things he could have said to me, because when you're in that crisis and somebody says the average person, stage 4, lives 2 to 3 years, which is what it is, it takes your whole morale down. So that was awesome that he said that. Decided to do radiation. In general, my health was good, and so managing the cancer, he decided that chemo was not a good option because that's killing your organs as well, and it's just harsh. So let's just see if we can work on tamoxifen and see how long I can go. So I got a radical hysterectomy down the road just last year, and that changed my medicine to another one. Doctor said, you need this medicine. Insurance said, we're not going to cover that until A, B, and C are failed. So we're going to put you on A. If you fail it, we'll put you on B. If you fail it, we'll put you on... Well, when you're cancer, you don't want to hear that. So we had no choice, really, unless I wanted to pay $6,000 a month for the cancer medicine that he wanted me on. Anyway, bottom line is I failed. So they changed my medicine. Now I'm on a new one. And it's working much better. I feel much better. What I want to happen, and I've tried to talk to the doctor about this, is instead of managing it, I want to kill it. I did get my genes tested. I do not carry the gene, so therefore it's my environment. So if it's my environment, we don't know what part of my environment, so I'm just going to change everything I can. Get rid of the plastics, go organic. Don't eat hormones, pesticides. You know, I just changed everything, worked on being relaxed. My number 1 risk factor for metastasis is stress. They took me off of work. I'm an autism specialist. Temecula has a great special ed program here. And that helped reduce the stress a lot. I go to Michelle's place. That's my other safe place. I do yoga. I do art expression. I would get these encouragement calls every once in a while, and they would just say, I'm thinking about you. How are you doing? And it made such a huge difference, because when you don't have breast cancer, you don't quite get it. So to get that phone call from somebody that's had it, it made a huge difference. They've been my stress relief, and I've gone to yoga weekends from them, and it's been a huge part of my treatment. What I want to happen, and I've brought this up for the last year or so, I'm a big researcher, so I know it's out there. I want to have a liquid biopsy and have my DNA sequenced so we can find the mutation and go for the targeted treatment. Now, when I first started bringing this up, there was only 13 FDA-approved medicines that would match up with a mutation. Now there's tons. The last I heard was 47, and I think that was a while ago. So when I brought it up to the doctor, he said, no, we're not going to do that. That's not our standard of care. We will wait until what you're doing now fails, and then we'll talk about another option. To me, waiting for it to fail is waiting for it to progress, and that's a little depressing. And it's It's not aggressive enough for me. So now that we've progressed and we've gotten these trials and we know there's a lot more targeted medicine, you can't do that in the Valley. You have to go down to UCSD or I know Stanford's doing it. City of Hope has a little bit of it. This is what I think we need here. We need to make it a standard of care here to do liquid biopsies, to get the DNA mutation, find out exactly what the targeted medicine should be, and go for it. What they do now is they put you on this, which is standard of care. When this fails, they move you to this. When that fails, they move you to this. When that fails, meanwhile, the cancer is mutating each time. So we have learned recently, because of Ibrance, a new medicine, a lot of times the mutation is changing from ERPR positive, which is hormone receptor positive, to HERS negative, which is very aggressive. But a lot of times we're not finding out till it's too late. So I'm in the METS support group at Michelle's place, and all my girlfriends are stage 4 like me. And last year we lost 7 girls. And I've seen these things that could have been done to prevent it possibly, prolong their life. Definitely, if we got targeted medicine that was more appropriate, that would have been better. So anyway, that's my concern, and that's where I'm at right now. And I appreciate you giving me time to hear my story. And I applaud you for your time and listening. So thank you.
One quick question, Natalie, one quick question. Where did you receive your care?
Like, what's my doctor's name?
No. One of the functions of what we're doing here as a task force is studying the need for services here in town. And so, or rarely in the region, I should say. And so I'm curious, all the time that you're getting your care, your treatment, your scans, everything that goes along with treating you, where have you had to go?
Okay, so, and I'm really happy about these places. BreastLink does all my imaging, and they've been awesome. They've gotten me in on Sunday night at 9 o'clock at night so that I wouldn't have to wait 3 weeks to get a scan.
Are they here in the region?
BreastLink is in Marietta.
Okay.
Yeah, over by Richie's Diner in the 215.
Oh, I know where it is.
Yeah.
Great.
They've been amazing. Now, I was under the impression they only have one mega CT scan, or MRI, it's an MRI in the whole valley, and it's there. So little claustrophobia, thank goodness I was there. They stuck me in the mega MRI, and I could do that one. My radiation was at Red Hawk off of South 79. Excellent treatment there. Really great people. Loved it. Great experience. My oncology is at Hematology Oncology over by Loma Linda, Dr. Sagal. And Dr. Sagal and I have the same way of thinking as far as less medicine, more natural. But I understand that they have a panel there, and so there's a lot of pressure for the standard of care to be a certain way, and that's where I get frustrated. But as far as him as a doctor, I really like him as a doctor. And they have been really good. They're overloaded there, but they've been really good about getting me in. And what I've learned in my process is that I get the referral by hand, and I hand walk. I call the insurance, make sure it gets approved, and hand walk it over to where I want to go. So things for me go like this, but most of the time it would take weeks. But that's just me, because it's my life. I've got 3 kids. I'm stage 4, so I'm really aggressive about it and advocate for myself.
Natalie, thanks for you sharing your story with everybody here.
Sure.
It's very helpful.
Okay. Thank you very much.
You're
Thanks
welcome.
to all of you. And Michelle's place.
That's right. Our next testimonial will be from J.J. Petchel. J.J.?
My name is Tanya Petchel, and this is my story. I have always tried to take good care of my health. I have never smoked, rarely drink, and have always tried to eat healthy. I ran 18 races in 2014, and I decided I would complete a full marathon and began what I thought would be a year-long training program. However, I began to feel pain in my side that became constant. So I went to my doctor to see what was wrong. I was 45 years old, but in the best shape of my life. I was shocked to find out in May of 2015 that I had stage 4 liver cancer and told would only live a few months. There wasn't many treatment options. Getting this type of news is harder than anyone can imagine. Fighting cancer is difficult and overwhelming task. I have had 19 chemotherapy treatments, 8 surgeries, including 3 specialized radiation surgeries. But I am currently in a clinical trial to fight the cancer at a DNA molecular level. I want to thank my husband, JJ, for spending countless hours of research and finding these state-of-the-art treatments. They are definitely the reason I have beat the odds and why I am here today. I was in tears when I got the call because the doctor had just told me that the clinical trial my husband found likely would not work for me. I'm happy to report that the clinical trial is working. My cancer tumors have shrunk more than 40%. Thank you for all your support and prayers.
It's still hard for me to watch that. I want to start off by saying that Natalie and I only met just here, and this is a bizarre coincidence of what I'm talking about and what she talked about. But my name is JJ Petchel, and my wife Tanya and I have been Marietta and Temecula Valley residents since shortly after we were married in 1993. Unfortunately, Tanya passed away on January 24th from a blood clot, which is fairly common in cancer patients. But as you can see in the video that was filmed just a few weeks before she passed away, she was doing extremely well, and despite her stage 4 liver cancer and the original prognosis of just a few months, everyone was surprised by her death because the DNA-based treatments that she was receiving were working. You may have heard of former President Jimmy Carter, or Ricky Rocket, the drummer from the rock band Poison, being declared cancer-free after receiving DNA-based treatments called immunotherapy. Through Tanya's cancer fight, I learned that people are dying every day that potentially could have been cured or have their cancer suppressed to live longer without extreme side effects. And this is not science fiction. This is something that is happening right now. These treatments, this is the treatments that experts believe will be a cure for cancer because scientists and doctors are able to cure a significant amount of patients right now. Although these patients are typically in clinical trials and the treatments are not experimental treatments. These are typically FDA-approved medications that either target and kill gene mutations in a specific cancer patient, or the medications activate the patient's immune system to kill the cancer like it should. Doctors and scientists are literally figuring out how to help more patients every day. With the help of several of the top doctors in the field at UCSD, I have created Tanya's Law with the intent to become a proposition in the 2018 California general election. Tanya's Law is an insurance-based law to allow every cancer patient the opportunity to have their cancer DNA tested or DNA sequenced, as Natalie is a more technical term used. Additionally, Tanya's Law will require coverage of the FDA-approved medications to treat these patients and eliminate the bureaucracy that hospitals and doctors have to go through to get the medications to the patients. My vision is a California proposition, but then to take this to a federal level, and if necessary, to challenge the FDA to update their approval process to include genetics. But Tanya was a Marietta resident. I am a Marietta resident and a business owner. Let's start right here in Riverside County. You've all received a brochure on Tanya's Law. I encourage you to read that site tonight, and thank you for your time and consideration. Thank you.
That you're doing here, and a lot of times that's exactly how it occurs. So, God
Thank
bless
you.
you.
It is a little overwhelming that I personally have a motorcycle parts business here in wholesale. Why isn't this happening? I consulted with the doctors who are actually doing this at UCSD, and I couldn't believe how excited they were. Dr. Ezra Cohen at UCSD was emailing me while he was on vacation, which I just blown away by the support already, and I know this is huge, and I need help. I decided I was going to do this. It is happening, but it's going to take a lot, and it's a big task, but it needs to be done, and these treatments, the way we're going, this is all going to happen 20 years from now, 15 years from now. The treatments and the testing, everything's available now. This should not take 15 or 20 years. This needs to happen now because people are dying right now.
You know what I think we should do as well, as you dive deeper in what you're doing with the state legislature, this group here, Southwest Riverside Cancer Task Force, could probably help you support that.
That's what I'm hoping.
Via letters. Also, you have a number of cities represented here, perhaps resolutions from the respective city councils up to the state legislature in support of that. So perhaps you can begin to get, if you get it to our staff, the City of Temecula staff, we'll make sure we disseminate it to all the respective cities, and maybe we can lend a hand some way.
So can I ask a question?
Of course, yeah.
Mr. Petchel, thank you very much, because I know how difficult this must be for you. So the question is to you and the doctors in the room. If we have a choice between a cure and control, why would we not automatically go to cure? Anybody?
Say that again?
We always aim for a cure first and foremost. Sometimes that's not achievable, and so we have to be honest with patients with the limitations of what is available. And although we want to be positive, we also do not want to give false hopes. In reality, right now, a lot of these new treatments, you're right, are now available commercially. They have been FDA approved. What I see as the biggest barrier to care, and I see it every day, is the cost of the drugs. These drugs cost thousands of dollars per dose. And although insurance has to cover it because they are FDA approved for the indication, patients' copays can sometimes run in the hundreds of dollars, sometimes thousands of dollars. And that is the biggest barrier that we as physicians have that will prevent us from treating the patients. Now, we do in our practice help find assistance. We do our best to find any copay assistance or any, there are foundations out there that can help patients pay for their medications. However, sometime, like now we're approaching the middle of the year, most of these funds have already run dry. And it is really, really very difficult. You know there's something that works, but you cannot give it because the patient does not have the amount. So I was just thinking about here, if we really want to make an impact in this community, that maybe we can start a foundation that will help patients with their copays. You know, that will take something like a big group like this to start such a foundation. That will really create a big impact in terms of the patients are going to get the latest and the best treatment and in a timely manner, because we're not running around looking for money to pay for these medicines.
Wow.
I'd like to add to that. So I have, I consulted with the UCSD doctors who are doing these treatments, and if Tanya's law passes, the insurance companies it'll be illegal for them not to cover the testing. It'll be illegal for them not to cover the medications. It will be illegal for them to make it difficult to get the medication to the patient based on the location of the cancer in the body. If the genetics match up to the FDA-approved drugs, the medication has to get to the patient in the same more simple procedure as if the location, say breast cancer, this is a breast cancer drug, the same way, the same ease of treatment. And that's why my big vision is to, hopefully the FDA changes their policies, but if they haven't, within a couple of years, to try to force them to get more modern with it, that they should be approving medications based on location, but also the genes that the medications target. So I understand exactly what you're talking about, these costs, but this is the answer to those costs.
Yeah, I totally agree with you, because the old way of drugs being approved was site-specific.
Correct.
So if drug A is specifically approved for breast cancer, you cannot use it for kidney cancer because there is no FDA approval and insurance will not pay for it. However, cancer understanding has evolved so that you are able to determine any molecular changes in the tumor, what makes it grow. And it could be breast, it could be lung cancer, but they have the same genetic mutation. So the same medication targeted to that specific mutation should work.
Correct, yeah.
So
yeah.
right now, it's still the same stepwise manner. Drugs are approved one at a time for each specific site of cancer. And
Right.
you are absolutely right. It's changed. There's been a revolution in cancer understanding and therefore cancer treatment also.
Yeah, I really believe that when we talk about cancer, we're still talking about the location in the body, and that's like talking about the world being flat. And we're still doctors and patients and everybody that ask, what kind of cancer? Well, the question is, where is your cancer? Because two people with the same location, be breast cancer, will go to the doctor, they'll get the same treatment because it's the same location. It'll work on one patient, it won't work on another patient, and they'll be baffled of why it didn't work on the other. Well, the reason it didn't work is because it's not the same cancer. It is the same location, but the cancer is completely different. When they do the DNA testing, it is, they'll find that the cancers are different, they need to be treated differently. And again, these treatments, this isn't the future. We hope we can do this. They can do it. It's just a matter of what can we do to speed this whole process up. And you know, with what I know and what I went through, how do I stay quiet? And I know people are dying that don't have to die. So what's the biggest thing I can do? Well, I've got to start here in California, but again, I want to start here locally. But this is a federal level. I would love to get into the ear of President Trump and give him the opportunity to change the cancer industry, to educate the world that it's not flat anymore. Location isn't the most important thing. The genetics are. And I hope some people in this room will either have the ability to do that themselves or have the connections to help me do that. I don't know.
Dr. Mendoza, I think your idea as far as a foundation, you've given us a little something for our next agenda. We can talk about that. So perhaps, Erica, we can get that on the next agenda. Mayor Gibbs, you good?
When you leave the podium, I'd like to talk to you.
Okay. I'm happy to talk to anybody for as long. I was really concerned about the time frame, so I got this very short. It can be very complex. I assume a lot of people, even if you're in the industry or work for a hospital, you may not really be up to date on the DNA and genetic testing and treatments, and that's okay. That's what we're trying to do. But I'd also want to just add before I step away that I'm trying to pass a law to help patients, but the education alone is something that I think this task force can do with almost everything that you are involved with, so that the patient goes to the doctor and asks the doctor about the DNA testing, and if they're not getting that option, well, why not? And push, supply and demand. Let's create the demand so that everything else, all the problems that it will create in the hospitals with the insurance, everything else, it'll all get resolved. But let's put the accelerator on this whole process and let's help save some lives.
Again, thank you for coming and sharing a very personal story. I appreciate that. I think some good's going to come out of a very terrible situation.
Yeah, it's very recent, so
Yeah.
thank you.
You're very welcome. Thank you. And our last testimonial will be from Andrea Anderson. Andrea, are you here? Welcome today.
Well, a little bit of my thunder's been stolen because the segue from our last testimonial was Dr. Mendoza offering about the financials, and that's really what I wanted to talk about today. A little bit about my background is that I am an office manager for one of the community medical oncology practices. And so one of the things that I think most of us, unless you are in the industry or you understand insurance, are very ignorant about the actual costs of cancer care. And I thought it was very relevant for where we were going with, the GAP study group being solidified, and, naturally the conversation was going to segue to these issues. I brought some data just to focus on the financial reasons that you want to support community oncology, because it is the least expensive side of care for patient care. And Dr. Hayton, at the very first meeting, I thought brought it to the attention of everybody that university level care is available here in this valley at this time. And that all of the community oncology practices, Dr. Shinky Mendoza's group, Dr. Hayton, Dr. Tsai, Dr. Calder's group at C-Care, we do coordinate with those larger facilities. But the testimonial that I want to give is not my testimonial in that I did play a part, but it is a patient of ours who had the experience of having a very unique and aggressive cancer that after we had treated needed to be transferred down to UCSD for their care. And so one of the medications that they had been given at the facility, I knew the drug manufacturer had a copay card that could drop this patient's high deductible, which was $7,500 at the beginning of the year, and this is January, down to all of $25 for that one drug alone. So I registered the patient. It was all in place. I had my plan. The patient was approved for $25,000 grant from the drug manufacturer for that particular drug. When it came down to the actual billing of those services, because the facilities don't bill with line items, and that drug code was not on a separate line when they sent the claim out, the copay card was moot. It could not be used. So it was like, being in the Wizard of Oz and finding that the wizard was behind all of the mechanisms. I had no idea that that's what happens. community oncology, just like Dr. Mendoza said, one of the things we do best is we find resources for our patients. I am in my office every day looking for money to help my patients afford their care. And though FDA approval is great, forcing insurances to pay for it is great, you're still subject to your insurance policy. If you have an 80-20 policy, you're still going to be subject to that 20%. Yeah. And if I can't find foundation money, if you're a Medicare patient, or if the drug manufacturer doesn't have a copay card to cover that amount, the patient will be responsible for that. And that will be thousands and thousands of dollars with these targeted drugs. So again, thunder stolen. Dr. Mendoza, you're on the right course, because I really believe that this valley needs a foundation of its own. The first meeting, we had the epidemiologist here, and some of the statistics that she put up were just appalling, that this valley, this Riverside County, has a 20% higher incident of cancer rates than in similar demographics. I mean, that just scares me. I raise my children here. I live here. I work here. And that means I'm subject to that additional 20%. So I think we have a unique opportunity as a task force and as these minds have been brought together to maybe do things that help our own financially, but also CMS, I believe, has an innovation award for new ways of delivering care, whether it's cancer or other diseases. And if it may be available to this committee or to the group or to whatever organization is formed to seek some of that funding from the federal government to change the way cancer care happens, the way it's diagnosed, the way it's treated. Can we keep the costs down by preventing our patients from leaving the valley, keeping them out of the hospital because they have all the support medications, they have the hydration they need. We're protecting them from the environmental issues. I think we could be a model for the rest of the nation. And I've discussed it with people in my industry, and they're kind of looking at us because we have a great amount of demographics to kind of model against the rest of the country. In fact, Green Bay, Wisconsin's population number is the same as our little valley. They may have the Packers, but maybe we can have the best cancer care and support here in this valley than in the rest of the nation. I mean, I'm excited about what the potential has. And that was kind of my 2 cents today. So.
Well, Erica, I think Andrea is going to play a big part in our next, in a future agenda item as we discuss financing and help with a foundation. I do have a question for you.
Yes.
And perhaps you can answer it. Let's say somebody's on Medicare. And they have their Medicare supplemental insurance. Will that take care of most cancer treatment? Or is there typically a gap with that?
Well, it depends on the supplemental. Mm-hmm. And key here is in the 21st century, as we're talking about the targeted medications. One thing that Natalie had mentioned earlier was Ibrance. Ibrance is one of those targeted medications for pathways. But the thing about Ibrance is it's an oral medication. It doesn't fall under your medical benefits. It falls under your pharmacy benefits. So what happens to my Medicare patients, and they are narrowing it with the Affordable Care Act, is this thing called the donut hole, okay, or the coverage gap. So on those, that Ibrance is about $16,000 cash monthly, okay? That's just a rough number. But a Medicare patient on the front end of their prescription policy will be responsible for 30% of the cost of that drug because they're on the beginning of their coverage, say January. 30% is thousands of dollars. And I know my Medicare patients, they don't have those resources to just lay out for a single fill of their drug that is going to fight their disease. And not only that, they're not replenishing those finances. So I work, and we work in community oncology very hard to find them the resources to afford that. So we're having the targeted medications, but 80% of the drugs in the pipeline are oral medications, and they won't be covered by your medical benefit.
Do you think,
So that's important.
when we come back and discuss this, one thing, because we've been having some of these discussions here in the city among management staff, and it seems to me, unless you're in the business, billing Medicare, what have you, you really, the average layman doesn't get a awareness on Medicare and what it is until they have to. And so we've been having discussions, as I've said, and nobody really knows for certain what does Medicare cover, and what are the supplementals, and what does the supplementals cover, and is there certain stages of supplemental? There's the really great Cadillac and the really, the A policy versus the D policy. When we have this item and we discuss it, could you bring that information for us? Because I sense that you have the bottom line on this. You're probably going to be able to educate us.
Well, from the side of how it affects my patients when they have inadequate policies, absolutely. Where, again, we're back to the wizard behind the veil, I don't understand the insurance agent side of that discussion. However, I have contacts that are in that side that I may be able to engage for that information.
And here's the simple question. Okay, somebody hits 65, they're eligible for Medicare, so they got it. But it doesn't cover everything, so that's question one, what does it cover in the scope of what we're talking about here? Then number two is there's the supplemental policies. Whatever you can bring regarding those supplemental policies, is there a spectrum, is there a range? What's the difference between what's out there, what's normal, just that information. And then what do those cover? And the goal here is, what I want to identify is there a situation that if you're on Medicare, and even if you have supplemental insurance, if you find yourself in a cancer fight, can you still be left destitute or bankrupt because you can't afford the treatment? Or, God forbid, you just don't get the treatment because you don't have the money.
Yes.
Answer is yes.
We need to find
Yes
that
to
out.
both of those.
Okay,
Yes.
okay, so I want to identify that, because I think what I see here is nobody knows, so we can't focus on it. I mean, it's just not common, but I think if we can say, look, your best case scenario is if you got Medicare and you got the best supplemental policy, you can still find yourself in a cancer battle that can still put your entire life in peril. Okay, not only your health life, but your financial life.
Yes.
Especially if the treatment you need is covered under the pharmacology side and not the medical treatment side.
Well, and that, very often I will have a conversation with a patient who's, deer in headlights, they've just got the cancer diagnosis. And their plan, because they've chosen a Medicare Advantage plan, great plan until they got cancer. Because what happens when they get cancer in their Medicare Advantage plan, very often their plan only wraps around the 80% of the allowable that Medicare does, and it leaves the 20% for the drugs for the patient to cover. And the good news is there's usually a maximum out of pocket, so that's the bad number. I tell the patient, this is the scary, ugly dragon we have to slay. And we have to, find the money and the resources. But the patient will ask me, well, I thought my insurance covered my medical. And it does, it just doesn't cover it all. And I have that same discussion when we deal with the cancer oral therapies, because they're not on a,
Right.
patient has Walmart prescription plan. Well, they can't get the medications at Walmart, nor will they ever. And it's not on a tier, it's a percentage pay, and it's always starts either at 30 or 45%. And so regardless of the plan they choose, if they have Medicare Part D, that is their prescription plan.
Now, you said Advantage plan, you said Medicare Part D, and although I'm certain there's people in this room that know exactly what that is, I don't even know what those things are, and I bet you there's a bunch of us in here that don't either.
This is my passion.
I
I
could
would love to
tell.
teach you, because I see the repercussions of that on our end. In fact, today I did battle for a patient of mine to get this person the medication that he needed, and it was $16,000 for the first fill. But I knew that I was going to get foundation help, because there was a foundation that was still open, And once that tapped out, because all they awarded him was $5,000, I said, and then we're going to the drug company, and because now you're functionally underinsured, you're going to get free drug. So I got this patient free drug for 12 months.
Wow.
So, what I'm seeing here is perhaps, obviously you'll help with the future discussions on the foundation, but Eric, I'm seeing a separate agenda item to talk about Medicare and insurance and supplementals and all that, and I think, Andrea, you'd be a good resource for that.
And I think that, because what you will find as you go further into the subject, with the agendas later on, the insurance contracting drives the referrals.
Mm-hmm.
So,
Yes.
you can bring in additional providers and services in the area, but if the insurance is not, if that's not in network, and more of these plans are not covering out-of-network services, those providers, won't stay because they won't have any referrals, and most of the patients won't be able to utilize the services.
So part of our mission needs to be to educate Temecula residents or regional residents about insurance.
I think if you can do that, you've empowered consumers to be their best advocate, because they'll make better insurance decisions, they'll have a better understanding of how to manage the costs, and we can have a better discussion, because I can deal with the truth, and I like to deal with the truth, because then we can come up with a plan to fight the problem. But as long as you keep it in the closet or this, enigma that people don't understand, they won't be proactive in helping themselves. And then, delay in treatment, or they just tell me I can't afford that medication, I'm not gonna get treated. I'm like, well, wait a minute, we're gonna find you that money.
Mm-hmm.
We're gonna make this happen. And if I can't, I'm not 100% successful, but I'm gonna do everything we can. And that's the way our community oncologists work. This is what our offices do well.
Mm-hmm. Exactly.
Well, that's critical.
Yeah.
It
We need
is.
that information.
Okay, any other questions?
Are there any other questions or comments? Yep. Dr. Hayton.
I'll just make one comment, and that is just what she described right now. You're not going to have that type of understanding, as Andrea said, you're not going to have that type of in-depth understanding by anybody at the tertiary centers. We here in the community, as far as cancer care, I can tell you testimonials from patients, but I can tell you just from observation of what patients get at the tertiary centers, there are things that they can do for which the patient needs to be there. But we can cover probably 95%, if not greater, if not 98% of all cancer needs right here in this valley. We have the resources, we have the skills, we have the talent, we have the technology. What we do better than the other institutions is just what Andrea was saying. You don't see that type of patient advocate at that level. And that's something that I think that we can leverage, saying that community oncology right here in the Temecula Valley is good, if not better in many ways than, the big monolithic, quote, cancer centers that you drive by on the I-5 as you're going down to San Diego or I-15. We have the same resources that they do in 98% of the things.
Plus the patient advocacy.
Andrea just told you about the experience of our patient at UCSD.
And that patient needed to be there. That's the thing. We participate joint effort with many of our patients that have those unique needs. It's just when it comes to that financial, that was so disappointing to find out that that's the case. And, I don't know who to reach in UCSD or the UCS system to change that. It's a procedural, and, there's software, I'm sure it's very expensive, but I see how it affects my patients. And, I thought I was really helping, and it kind of was moot, and that was disappointing. But anyways.
Well, you've brought us a very stimulating discussion, as did you, Dr. Mendoza, and also laid the groundwork for two very important agenda item. So unless you have something else, I want to thank you for being here. Yeah.
One more thing, just one more thing.
Sure.
Regarding the co-pays
Mhm.
and how important they are, there is actual state assembly bill, let's see, 265, and it's been up for discussion this week. It's euphemistically called the Wood Bill by its originator, and this bill would ban patients in California from receiving copay assistance programs from pharmaceutical manufacturers when a therapeutically equivalent or interchangeable brand or generic drug is available at a lower cost. I read the language of the bill that's in the assembly. It's very broad and ambiguous because who's to determine what is therapeutically equal?
Right.
And I understand the intentions in the bill are to bring drug prices down, attacking the pharma, but it is gonna hurt my patients. They won't get their drugs. So,
And in some cases, there won't be a therapeutically equivalent drug.
yes, the biologics are not biologics are very unique. You're in again, targeted therapies, you can't say that there's going to be an equal to that. I mean, they're just different pathways. And so this is real. We're all voters, hopefully, here. And Melissa Melendez is our local state assembly in the 67th. So I contacted her office, and she asked for more of us to contact them and voice our opinion. So not to persuade you all about my opinion, but I would like you to do your own research because it's going to affect cancer care as well.
And in Temecula, it's Marie Waldron for the most part.
Okay, great,
Yeah.
great. But I'm Murrieta, so that's
That's
fine.
okay. Yes.
So it hasn't, I'm not sure how it's processed, but they were supposed to be talking about it in the assembly on the 18th, which is passed. But keep an eye out because it has to go to then, if it passes, then to the state senate.
Let's do one better than that. And
I
boy,
talked to Jeff Stone's office.
And this is excellent. I think, boy, you're giving us a lot of good stuff for the future. I think that perhaps we need to include in our agenda for the next meeting a legislative update. And the city has state lobbyists. Mr. Mayor Gibbs, does Murrieta have a lobbyist up in Sacramento? I figured as much. So we can get all the information we need. And again, our power here as a regional task force is speaking with one voice. In particular, not only all of you folks in the healthcare industry, but us as the cities. That's what we're here for. And so I think we need to get these legislative updates. And if we all decide that it's a good idea, then we'll obviously contact Marie Waldron and Melissa Melendez, both very good assembly members, and also Senator Jeff Stone as well.
Perfect.
So it's
And
AB 256?
yes, AB
Okay.
265, sorry.
Oh,
AB
265.
265
Okay,
is
and
the
it's
bill.
wood.
Yes.
Yeah.
So, thank you very much.
So thank you
Right.
very much for your contribution. So we're going to move on to our next section of the agenda is presentations. Item A is our very own Cheryl Kitzero to talk about our current multi-agency funding status. Is that, you're going to handle that, Erica?
No, Cheryl's going to come up. I'm just doing a couple of introductions and administrative items. So,
Okay,
just a quick reminder for everyone, our remaining task force dates are here. You will receive email updates from our lovely Stacy Brown, who's in the back there and did all the organization for today, so a big shout out to Stacy. Obviously, as you've just heard, we have 3 agenda items already for the May 25th meeting. We'll be looking at the formation of a foundation to assist patients with the cost of cancer care. We'll have an update on insurance and Medicare options, and finally, some legislative updates. Today, as Councilmember Nagar was mentioning, we have 2 staff updates. The first one will be Cheryl Kitzero, who will be providing an update on the status of our funding, and then I'll provide an update on the results of the RFP.
and Cheryl, as you're coming up, I want to apologize to everybody. I have a community meeting I need to get to at 6 o'clock, and it's in Menifee, and so I'll have to leave here in about 5 minutes. But I did want to say something about your first presentation, so I'll turn it over to you, but if I interrupt you, it's not because I'm rude. I just wanted to say something.
Okay, fantastic. Thank you, Mayor. Councilmember Nagar, members of the task force.
And pull that microphone a little closer to you there. There you go.
Is that better?
Perfect. yeah.
Perfect, okay. So at our last meeting, I stood before you to explain some of our funding options and to ask for funding pledges that would cover the costs for both health needs assessment and a task force facilitator. Without getting too far ahead of ourselves on the agenda, Eric is going to share more about the proposals and the consultants. Let me share the confirmed pledges that we've received. As you can see on the screen, funds are proposed from several different sources. We have a total of $85,000 pledged for this work effort. City of Temecula and City of Lake Elsinore have both submitted applications to the Regional Planning Agency for a total of $30,000 through the WRCOG Beyond Core funds. Those funds are allocated funds, so those are for certain monies that will be coming to us. The same with Supervisor Washington's office. He has pledged $20,000. Those two are from core funds that will be for certain coming to us. And then City of Menifee and City of Murrieta have submitted to WRCOG for their Beyond Health grant. The $7,500 for each of those are competitive grant funds, so that's why you'll see the asterisk there. With or without those funds, the consultant that we are going to be working with will make this work for us. And then lastly, IEHP has confirmed their pledge for $20,000, so we are in great shape.
And this is where I'm going to interrupt you.
Okay.
Okay, because I did want to say, at our last meeting, we talked about if we can't get the funding, then we're sitting here and our whole effort is in vain. And I just want to thank everybody, in particular the cities, because the cities came through. We got to deal with Menifee and Murrieta on the competitive aspect to this and find out what's going to take that over the hill. Mayor Gibbs, if you need some help, or support, you just let us know. We'll go gang up on Rick Bishop, okay?
They've applied.
All right, over WRCOG. But I just wanted to say that's outstanding, and I'm going to leave it at that and turn the meeting over to Mayor Edwards and Mayor Gibbs, and I just wanted to thank everybody.
Thank you.
Thank you. Okay, Cheryl.
That concludes my portion of the agenda item, so if there are any additional questions or comments, I'd be happy to answer them.
Are there any questions? Any members? No? Participants? Okay, thank you, Cheryl, and we'll follow up with any cities that need support through WRCOG or any of the funding sources, so thank you. Okay, so Erica, you've got an announcement about the consultant.
Right, so if you recall last time we met, we were kicking off the RFP process and we appointed an advisory committee. One of the first things we had to address was the limited funding. Originally, we had hoped to have about $150,000 to allocate to the process. And at that time, prior to the two competitive health grants Cheryl just described, we had about $70,500 committed. So one of the first questions we had to address was how we would handle coming in with less money than we expected. Our options were to narrow the scope or duration of the assessment, to identify contingent elements that could perhaps be implemented at a later date if additional funding became available, or to eliminate the facilitator role. And if you'll recall, we were going out for two separate RFPs, one for a facilitator and one for a community needs assessment. We conducted both RFPs. We received about 24 interested bidders. In the end, we received 4 complete proposals, 1 for the facilitator role and 3 for the consultant. Staff reviewed those for completeness, and then we forwarded those to our advisory committee. The advisory committee reviewed the proposals and ultimately made a recommendation. At this point, I'd like to thank those members of the RFP advisory committee because I know everybody's schedules were crazy and we really appreciated their expertise. So it was Kim Goodnow, Darlene Wetton, Dr. Nahas, Dr. Horner, and then we had 2 sort of in the background. They weren't formally able to sit on the committee or make recommendations because they were familiar with most of the respondents, but they were able to kind of give us conceptual level advice, and that was Salome Waga, our epidemiologist who isn't here today, and Aaron Bizak. In the end, the successful proposal came from HARC, and they were selected for a combination of the comprehensiveness of their proposal, their familiarity with our region, their previous demonstrated performance, notably the Kaiser Community Needs Assessment they had conducted, their ability to fulfill both roles, both the facilitator and the consultant roles, and thereby achieve economies of scale, allowing us to work within our funding limitations. And finally, and most importantly perhaps, their flexibility and scalability in terms of being able to work within the limitations we were dealing with at that point. So at this point, if there aren't any questions about the RFP process, I'd like to turn it over to Dr. LeCompte-Heinley from HARC, and she will be jumping right into her role as facilitator of the process.
Thank you, Erica. And welcome, Dr. LeCompte-Heinley.
Thank you all. I can just say that we are so thrilled to have been selected, and so glad. Hold on, let me just get the slideshow running from beginning. There we go. We are so thrilled that we were selected. This is exactly the bread and butter of the type of things we do. And so today I wanted to give you first an introduction to who we are, what we do, how we work, and then to get a little bit of an introduction from all of you. And I know you all probably know each other quite well, so please forgive me if it's a little redundant for you. Then I'm going to cover a little bit of the overview of the process and the timeline, what you can expect from us in the next 6 months. And then if we have time, we're going to jump right in and get started. If we don't have time, that's fine. We will follow up with you. So first off with the introductions. So HARC is a nonprofit. We are focused on research and evaluation that is in support of the social determinants of health. So not just healthcare, but also all of those things that contribute to healthcare, like socioeconomic status, like safety, like housing. So we were funded originally in 2006, and the idea was, very similar to your valley here, we're located in the Coachella Valley, was that we have unique needs that county level data just does not capture. And I'm sure the exact same is here. So the idea was, let's get a sub-county, community level status of our health and wellness. So we've been doing that for 10 years now. And in 2009, we expanded to provide other services. So the idea is we have all these big brains at HARC. There's no use just having them at HARC. Let's help them out. So we do a lot of services for organizations that might not be big enough to have an in-house evaluator or an in-house researcher, but they still want that good, hard evidence and that solid objective data. So as Erica mentioned, we did some work for Kaiser Moreno Valley and Kaiser Riverside, and we just absolutely love Cecilia Arias. We also help Susan G. Komen, several of their affiliates, but most importantly for us here is Susan G. Komen Inland Empire. Every 3 years we do their community needs assessment, and most recently we did one for Komen San Diego and Komen LA as well. So there will be a lot of familiar faces. Salome is a great supporter of ours, and I know a lot of the entities and the organizations here. So we do feel like we are in good company here. And I want to introduce two of the other team members that you will be seeing fairly frequently. Dr. Casey Lear, wave, Casey, is my director of research, and Ivy Torres is our research associate. So the three of us will be working on this. Even if it's just me that comes to present, know that there's others working in the background. Also, we just received confirmation today that we will have a fabulous intern working for us who attends UC Riverside, so he'll be joining us too. So there's lots of people that will be working on this brainchild. So one thing to note about HARC is that our process is very collaborative. We do community-based research, so we're not talking about in the labs, we're talking about with people. So we want you all to feel that you have every opportunity to provide feedback. Our whole point is to provide you with the data you need to do great things. And so we want to make sure that we have every opportunity to get your feedback and make sure we're designing a tool or a process that will get you that information you need. So we're available at all times. We'll be here at all of those next scheduled meetings that Erica mentioned. And since there will be a lot of work in between those meetings to gather this data, you'll probably see us a lot more than that too. And the way that we sort of see it is that you all are the subject matter experts. You've got great expertise in cancer and reimbursement, insurance. You know so much more than I do, Andrea. I'm really impressed. And you know your community, and we know data. We're complete data geeks. So the two really marry well together. So one of the ways, while collaborative-based research is a fantastic way, one of the things it takes is some very clear communication. We can't have communication breakdowns. So one of the things that I like to do as the very first step is to identify who's a liaison for each of us, because that's the one person that everything should go through. That's the one person who knows every moving piece. That way the ball doesn't get dropped on either end. So for HARC, that's me. I will be CC'd on every email, I'll be on every call, I will hopefully be in attendance at every single meeting. And as various tasks happen, I will delegate them at HARC or do them myself, but I'm the one that everything should come through. So my first question is, who should that be on the task force? I put Erica with a question mark because she's who we've interacted with so far, but I wanted to make sure that was appropriate.
I think that's appropriate if if that's the concession.
Okay, great. So then, as I mentioned, this is 6 months is a pretty aggressive timeline for getting a needs assessment this substantial done. So it's going to take a lot of communication between meetings. Obviously, you can't get everything done at a meeting. So I have some preferred communication methods here, all the way from sort of very hands-off, almost one way, down to very hands-on, in-person, face-to-face. So take a look at these and start thinking in your mind what works best for you, because it's our job to interact with you in whatever way works best for you. So if you hate emails, let us know, we won't email you. If you hate phone calls, let us know, we won't call you. So this is really to make sure that we're tailoring our conversations with you that happen offline outside of this meeting in the best way possible.
Well, I can tell you right now that the way we communicate most frequently is via email.
Excellent.
And with so many personalities in so many different fields, that's probably the most common, because I know there are people in here who probably don't do social media a lot.
Great. That's good. I'm a huge email person, so I love hearing that. So another step in making sure that we have clear communication is establishing RACI roles. So RACI is an acronym for who is responsible, accountable, consulted, and informed. So responsible is the people who are doing the bulk of the work on the ground, doing the work. Accountable is the one person who's ultimately accountable for the completion of the work. Consulted is a two-way relationship, so we present something and solicit feedback. And informed is more of a one-way. We say, here's what we've developed. So one of my favorite ways to talk about this in a little bit more concrete terms is about pizza. So in a pizza parlor, the responsible person is that chef who creates the recipes, who makes the pizza, who's there every day selling the pizza. The accountable person is the owner of the pizza parlor, and they're the one who has to pay the rent, they pay their staff, they pay their taxes, etc. Now, notice that in some settings that might be one and the same person, and that's okay. Then there's the consulted people. If you're smart about it, you go talk to little Italian grandmothers and you say, here, try my pizza, what could I do better? You could also go talk to potential customers, say, here, try this, how much would you pay for this? That's the consulted role. And then there's the informed role, where your friends say, hey, how's your pizza parlor going? And you say, it's great, we have this new flavor, I think you'll really like it, come on down, it's $6 a slice. So that's my example of the RACI terms. So for us, on the HARC end, I will be the one who's both responsible and accountable. And now I wanted to get to know each of you a little bit better, and Ivy will be taking some detailed notes here. And again, I know you all know each other, so please forgive me if this is a little redundant, but I'd like to hear your name, title, and organization, and where you see yourself on that RACI scale. And again, if there's a favorite way to communicate between meetings other than email. So, Dr. Mendoza, why don't you start?
So can you put the previous slide back up?
The pizza one?
Thank you.
Or the other, or the one before?
Yeah, either one, so that we can just see the different categories.
I'm Dr. Mendoza. I'm one of the local medical oncologists. I work with hematology oncology consultants. There's 3 of us oncologists. And I actually probably work better with phone call because I can answer that question in a snap as to versus looking for that email in the thousands of email I get every day.
Great, and that's exactly the sort of thing we want to know, so we will be contacting you via phone.
Oh, by the way, I'll be the consultant.
Okay, great.
I'm David Horner. I'm family practice. I'm also a cancer survivor, and I'm next door neighbor of Michelle's place. And preferred contact, like Dr. Mendoza, probably cell phone, just because this emails can get buried, and I can answer that question right away on the phone. And then also, where do I see myself? More kind of like the glue that connects than the consultant, but I guess on the ground, boots on the ground. That's how I describe it.
Great, responsible. I will tap you for a lot of things then.
So Jenna, if we could just go out of order for a second, because I know Mayor Gibbs has to go, so, and we definitely don't want to leave him out.
Sorry to preempt. Rick Gibbs, Mayor of the City of Marietta. I'm somewhere between informed and consulted. You can feel free to consult me. Email works great. And while put it bluntly, pancreatic cancer took my wife 3.5 years ago. It took her brother. It took her father. So our family is in a Johns Hopkins familial study for the East Coast branch and in a Stanford study for the West Coast branch.
Wow. All right, thank you.
There we go.
Great, thank you. I'm Peter Baker. I'm the administrator of the Loma Linda Marietta Hospital.
Ah, fabulous.
So I guess I view myself maybe as a consultant as well as, I don't know, however I can help facilitate or get you information or help support the process. I'm here to be there.
Great. And are you an email or a phone person?
Oh, I am a email.
Okay, great.
I'm Dr. Hayton. I'm also one of the local oncologists. I'm in solo practice for myself. I would say that I could serve as a consultant. One other form of communication that might sort of be might play into the phone call would be texting.
Okay, great to know.
You know, I think that texting saves my message right there.
Mm-hmm.
With voice recognition, we can leave long texts, and that would be a better way of communicating, because that way I would have the...
Great. I love that, thinking outside the box, and we are definitely comfortable doing that too. So,
Okay.
Thank you.
Hi, I'm Kathy Zappi. I'm with the American Cancer Society, and I'm here also representing Susan. And I would say we're probably consultants, but we also have a lot of information and data within our system, a lot about resources within the community. And one of the things we put together was resources and information. So I think we can kind of help in a couple of different ways. Definitely email. I'm good with the telephone as well. And being a nurse, I tend to be more also personal communication as well. So
Great.
however you'd like to work.
Well, you know, our next section after this will be talking about where to get data. So it sounds like I will be calling you to
And
get
resources.
that. Fabulous.
I am Mary Ann Edwards. I am the current mayor of Temecula and longtime city council member. And I believe that I'm going to fall in the range of consultant also. And I always feel accountable to everyone. So I don't mind, you know, being in that position. And we have terrific staff. Erica's phenomenal, as you know. So, and if you could also include our city manager in any email communications, that would be great too. So Aaron, I don't know if Aaron's here, or Greg.
Okay, great.
So that's good, and email is good for me, and text is good for me also.
Fabulous. Ivy, is this going too fast, or are you getting it? Okay, great.
Hi, I'm Cheryl Allred. I'm a director over at Loma Linda Marietta, and I oversee our cancer program.
Wonderful.
So I will help you in any way that I can, and email, text, any of it works for me.
Fabulous. I can see we will be in touch a lot then.
Hi, Jen. I'm Mike. Getting feedback from somewhere here. This is a bit of a tag team also. I mentioned Alice Feng, who the two of us are here. Alice is more of the analyst. And so, you know, we kind of pair what we're doing. I would say I'm the informed.
Okay, great.
I can be the conduit to consultant support through Scripps MD Anderson. So that's kind of can cover both those. And
Wonderful.
either me or Alice. And you'll see one or the other of us here, maybe not always the two of us.
Great.
Hello, I'm Marilyn Watson. I was one of the founders of Michelle's Place in this area, and I guess I would be considered a consultant also, and either email or text. Most of it will go through Kim, however.
All right,
She's the
we'll keep that in
executive
mind.
director.
Thank you.
Hi, I'm Kim Goodnow. I'm the Executive Director of Michelle's Place, Breast Cancer Resource Center, and we've been providing services for 15 years to breast cancer patients and anyone who can utilize our resources. We provide support services, so consultant in any way you need help, and any form of communication is fine, but email is probably preferred.
Great.
Thanks.
Great. And now, is there anybody over here that I should know about that might be part of the responsible, help us do the work, or that I need to consult with? Please pipe up now. It sounds like city manager, yes. Great. And email's good. Okay. Yes. Love it. Wonderful. Beautiful. You know, I had several hospital CEOs on my board before, and it was very hard to get them all in the room at the same time. So I understand the competing priorities. Fabulous. Sir, in the back? Ah. I love hearing that. That is going to be... All right. You are going to be absolutely priceless. I got to say, having media on board is the best way to recruit participants. So that is going to be very much appreciated.
We always say Paul is priceless. So.
Anybody else? Yes, sir. Great, thank you. And is email good for you? Okay. Wonderful. Okay, so thank you all. I know you all are familiar with each other, so I really appreciate you helping us get familiar with you. You'll get much more familiar with us in the next 6 months. So now I want to talk a little bit about the upcoming process and what to expect. So essentially, for those of you who did read the RFP, this is also boring, so I apologize. But for those of you who didn't, this is a little preview of what we see as the next steps going forward. So our first task will be gathering secondary data. So secondary data means any data that's already out there. I'm sad Salome is not here because I think a great deal of that is going to come from public health, and they've always been really fantastic about sharing data in the past. But I'm also interested to see what types of data you have. And the point of this is to see what information is already out there. What can we collectively understand from that? And what can we learn about the status of cancer in this community? I understand Salome has already presented some great data for this region, and we will get as much more as we possibly can. Then you look at that and you say, okay, this is what we know, and this is what we don't know. The what we don't know part, which we want to know, that helps us design this Community Health Needs Assessment, or CHNA, which is, you'll see me abbreviate it that way. So this is the idea that, all right, we know this, we don't need to ask things about this, but there are many questions that remain unanswered. One thing is that typically we'll be able to gather some great data on things like cancer incidence, prevalence, mortality rates, etc., but that doesn't really answer what are the barriers to getting care here? What are the barriers to getting the right type of care, to getting, one of the things that kept coming up was the cost of copays for prescriptions. And that, we hear that all the time in Coachella Valley as well. We work pretty closely with Paula Simons at Desert Cancer Foundation, which is exactly the type of foundation you were talking about, Dr. Mendoza, because their whole model is essentially that they reimburse for prescription copays and for various other costs associated with receiving treatment. So that might be something that comes out that we don't know from the existing data that we need to know. So that will help us design a community health needs assessment that will answer those questions, so that the combination of other people's data and data that's freely available out there and the data that we gather from the community will come together to tell us not everything we need to know, but a lot of it. So the way that we've proposed to do this needs assessment is first to survey the community, and all of those of you who work with cancer patients will be so key in helping us get that community perspective, but also talking to the providers about what their perceptions are, because there's really two sides to that story, right? The patient perspective and the provider perspective. So after we get those results, then sort of combining those and saying, well, what did we learn? What are the barriers? What are the gaps in services here? And what can we be doing that will overcome those barriers, that will ease the burden? What can we do? And then the last phase, and this is the one that we've done with Kaiser before, is, okay, what now? We know that these are the problems. What's our plan to address these issues? And it may be starting a foundation. It may also be, if you don't have enough cancer care providers, it may be finding ways to attract them, to retain them. So that implementation strategy, that what do we do, that part is very contingent on what did we learn, right? Because if the issue is there's not enough services, then that's an entirely different plan than there are enough services and people don't know about them, or there are enough services and they're not well connected. So that what do we do piece cannot be done until we first understand what the problems are. Because if you apply one solution and that's not the answer to this particular problem, we won't be able to see outcomes change. So, timeline. Casey, I have a stack of handouts there. Would you distribute them? They essentially go over this in a little bit more detail, but this is the general timeline for what you can expect. So, we'll get started on secondary data collection. We'll be in touch with all of you next week and looking at what data we can gather together to tell us this story. And we'll give you a report at the next meeting. It sounds like it's going to be a packed meeting because we already have at least 3 agenda items besides that. Then based on that, we'll be designing the survey tools and how we're going to go about approaching providers as well as patients and survivors and caregivers. Saying that now, but that's what I anticipate. But who that actually is will depend on feedback from those of you who want to be that responsible, boots on the ground, involved, consulted. So you will help us create that to make sure that it really is asking the questions you want to know. We'll probably begin data collection in early July. We'll give you an update at the July meeting, continue it through the summer, and then close data collection in time to do some data cleaning. We'll have some very, very preliminary analyses at the September meeting, but more formal ones in October, and that's where a lot of those of you who said you wanted to be consulted, you would be ones we would seek out on the survey design and also the report and say, what do you think? Many of you who are on the front lines of taking care of these particular people, you might have some different interpretations or a specific lens that we should be using to look at these analyses. So you'll be really invaluable there. In November, we'll finalize it and present the final report at the November 16th meeting, at which time we will really firm up the plans on, okay, how are we going to tackle this? Future meetings, we'll be a little bit more prepared for the next one, so I promise we'll have a little bit more detailed agenda. And that lovely for refreshments here, don't worry, we never have meetings without food. So even if they're subgroup meetings, anything like that, we believe in bringing food. Ivy's been taking fantastic notes, and we will be giving out meeting minutes no later than 1 week after these meetings. And where applicable, today might be a little bit less so, but where applicable, we'll have some action items highlighted with a specific person who, say, volunteered to help with a specific task and a timeline. So those will hopefully be very concrete action steps. So at the meetings, our portion of them will focus on sending updates on where we are in this status. So reporting out, that's for all of you who wanted to be informed, that's where you'll get the most information. It'll also be opportunities for some high-level feedback. Those of you who want to be more involved in the consultant type role will be communicating via your preferred method. And then also recruiting assistants. So for instance, those of you who are doctors, when we come time for the physician survey, I'm gonna say, hey, would you please take this interview or take this survey and, you know, help me recruit 5 more doctors, you know, or those of you who see a lot of survivors, I might say, hey, I have this specific survivors survey, can you help me reach these people? And media news, that will help us reach people who aren't already in our circles of care, who may be outside of that. And I think that's really crucial too, because oftentimes the people that HARC interacts with are typically very much like you. They're community leaders, they're leaders in the healthcare industry, and the people who we see are often those who have less need than the ones we don't see, right? It's the people who are not connected to all of your wonderful sources of care that we want to document their needs almost most of all. So I think the public relations and the media will be really important to getting those who aren't already in our sphere of influence and for getting some great info from them. So I was going to say brief break, but we're almost done, so sorry.
Yes, I say carry on, and quickly, thank you.
Yes. So actually, I'm going to skip, well, let's do this really quickly. Casey, would you come marker me? So one of the things, as we mentioned, and as you all wrote in the beautiful RFP, which very nicely done, thank you. Some of them are terrible. Here, we put that one up. Is we're creating that secondary data report. So looking at an assessment of what is the state of cancer care in this region, what are the demographics of our patients, and what are some epidemiological stats. So I'm realizing now that I wrote in the completely wrong color, so Casey, pick a different one when you write. But much of this will be, I wrote up a couple of places that I typically go to get cancer data. One is OSHPOD. Some of you may be very familiar with that. That's the Office of Statewide Health Planning and Development. They have great data on outmigration of surgical patients. Also the county, again, Salome is going to be an invaluable resource. But I want to know if anybody here has cancer-related data, whether it's for your city, whether it's for your company, anything that's below county level that might be useful for creating such a report, and if so, if you might be willing to share.
So you're looking for added resources?
Anything.
For information?
Data, yes.
Yeah.
Yes, resources is the next slide. So does anybody have cancer-related data or info that would help us get a better picture of care in the region?
You mentioned a lot of the sphere of influence that we have, not necessarily to a lot of the just regular members of our community that may not have contact to us regularly. I know as a family practice doc, and I know that a lot of us in our walk, whatever we do, if you're a business owner, you have access to a lot of customers per se, or people that you interact with. So I can speak from my practice, my partner. We have 6,000 people in our practice, and I would guarantee that almost all of my patients would be happy to fill out some kind of a short survey that would give us useful information. And they're just, that would be a good survey of just the general public of this area. We see people, as any provider here in Temecula, from Sun City, the whole area, and not just Temecula. So that'd be one good source. And I imagine that I could maybe drum up a couple of my family practice friends to do the same.
Great. That is going to be super, super useful.
Jenna, we have a database, obviously, of the clients that we serve. They all have breast cancer, or 90% of them do, but
About how many clients do you have?
we have 1,600 new cases a year. So we've got a lot in our database of the last 15 years.
Okay, so it sounds like that's a good database to learn from.
Yeah, so I'm not sure what you would need, and we can start tracking other things that you might need, but
Okay.
I'm willing to share with whatever we do have.
That's fantastic. That's half the battle. Put Michelle's place on the list. Honestly, we do a lot of work with the Desert AIDS Project with their effort to get everybody tested for HIV, and trying to get hospitals and labs and everybody and Planned Parenthood and everybody to share data has been a long process. Everybody wants to know the state of health, and everybody has their own data, but sharing is not always easy. So that's wonderful. Yes, sir.
I was just going to make a comment. There was every
Yes. That would be great. Definitely write that one down. Because, the cancer registry, just your general everyday person access is at the county level, and we obviously want to look below that. So that sounds like that might be below county level, which would be really perfect. So we will take a look at that rather than overall national cancer registry. So thank you.
I was just going to say the same thing. We use the cancer registry, and that's how we run our reports of our number one site and how many patients we see per year, all of that. So we could run reports for you.
Great. Even better. Love hearing that you have access and that you'd be willing to run some reports for us. Okay. So, Casey, why don't you now flip to a blank one? This one, you'll probably be a little bit more on the ball, is cancer resources. So one of the things we want to do is create a resource map, right? What resources are already in the valley. And you mentioned, sir, that you think we do have a bunch here. And I loved hearing about all the personalized service that you give, Andrea, just to your patients, and Michelle's Place is obviously a resource. Are there other resources that that you can think of that maybe have not come up, have not been mentioned here, that we should be aware of, that we can't maybe? Some of them we can find just by, Googling yellow pages, that sort of thing. But tell me about where people with cancer go for resources here.
Well, I can just let you know that we have a large database of all the resources that are available in the community, and as we learn of new resources, we add them into our database. So we
Love
can
it.
make sure to get that to you.
Perfect.
I'll work with Susan and we'll update it a little bit for you, but we presented it, I think, at one of the first meetings. So.
Great. Then that's done. We'll just take that from you then. Unless anybody has any that she might not be aware of. Or any that are particularly new or anything like that? No? All right. It sounds like your list will be the start of our resource map, so thank you. Okay, so I want to be sure to end on time because I know nobody likes to miss dinner. So in terms of next steps, we'll be in touch with many of you to via your preferred method to work out how we might keep you up to date, because like I said, this project is going to move very quickly, and it will move quickly between meetings as well. We'll be sending out meeting minutes with some action items like ask American Cancer Society for their resource list. That'll have action items like that. That'll be sent out within the week. And if you have any other ideas, data, resources that come to mind after this, I don't know that I did not put my contact info on here, but Erica will make sure, and it's on the handout. Please feel free to email me, call us anytime, night or day. And at the next meeting, we will be an item on the agenda to discuss what we've discovered and share our report with you. And then we'll move on to planning the needs assessment. Is there any questions for me about the process, about us, anything you have? No? All right.
Nope.
Well, thank
Great
you all
job.
so much, and we look forward to doing this with you.
Thank you, Jenna. So this has been a very productive meeting. We know we already had 3 agenda items scheduled, and Hark is going to add greatly to that list. So we will look forward to, with our key partners, to hearing from you as you gather data and establish what resources are available and where our outreach is and other sources of information that you need. And it sounds like there's a wealth of information in this room, especially, American Cancer Society and especially those who have, boots on the ground. Michelle's Place and our oncology groups, thank you so much for your willingness to share. I learned a lot today about treatment and the gaps, and it sounds like a lot of what our focus is going to be on is going to be the insurance and the education of our population as far as that goes, and we're going to be monitoring that legislation very carefully. I pulled it up on my phone and already sent a copy to Council Member Nagar and Mayor Gibbs of the bill, so we will be tracking that to see where it goes. So for all of you who were able to be here and your colleagues that you're substituting for who were not able to be here, we thank you very, very much for your contributions, and I'm very encouraged that we are getting the message that we have services available here, and maybe it's a matter of coordinating those services and educating our valley residents as to what services are available to them and how aggressive you all are in helping them pay for services. I was very encouraged in hearing that today. Temecula is all about community, and actually this valley is all about community, and that's the overall message I'm getting from service providers too. You care about the people you serve, and you go above and beyond every patient, one patient at a time, to ensure that they're getting the best treatment that they can get. So we look forward to seeing you back on May the 25th, and it's going to be a large, productive agenda. Thank you, Hark, for all that you're bringing to the table. And so if there are no further questions, I don't see any hands, then we will adjourn for today, and we'll see everybody back here. Thank you for your participation.